Good morning, everyone, and welcome. We are excited to have you here for this session of Take 10, Transforming Care for Women with Substance Use Disorders and Their Families. This is topic 5, considerations for treating women with SUDs that experience intimate partner violence and traumatic brain injury. Our presenter today is Rachel Ramirez. This presentation is brought to you by the ATTC and SAMHSA. The ATTC and PTTC are funded by agreements with SAMHSA. The opinions expressed in this webinar are the views of the speakers and do not reflect an official position of the DHHS or SAMHSA. ATTC believes that words matter and uses affirming person-first language when discussing behavioral health and substance use disorders. And just a few housekeeping details. If you are having any technical issues, please send an individual message to me, Ann Shensky, in the chat, and I will be happy to help you. If you have questions for the speakers, please put them in the Q&A section at the bottom of your toolbar, and the speaker will respond to them as time allows. The recording and PowerPoint will be made available on our website by the end of the week. If captions or live transcript would be helpful, please locate that option using your Zoom toolbar. And you will be directed to a short survey at the end of today's presentation. We really appreciate it if you could fill it out. It takes about 3 minutes. And certificates of attendance will be sent out via email to those who attend the session in full. And you can connect with us on Facebook and all of our other options. And now I'm going to turn it over to Rachel to get us started.
Good morning, everybody. Thank you so much for joining us. If you all wouldn't mind, if those of you who are out there, I know I can't see anybody, putting your name and where you're from in the chat box, that would be great. You can click on the chat box so it goes to everyone. But we appreciate you taking this very, very quick minute to be with us today. We have a very special, I always say, BOGO, buy one, get one opportunity that I have a colleague of mine, a dear colleague of mine, Cheryl Stahl, joining us here from Ohio, and I'm gonna just get us started with some of the presentation. Cheryl is, and we'll kind of introduce ourselves as we'll introduce ourselves real quickly, Cheryl, if that's okay. So Cheryl and I work together at the Ohio Domestic Violence Network, the statewide coalition on domestic violence here in Ohio of 76 member programs that provide direct domestic violence services across the state. I see people are from many, many different places. Every state has a domestic violence coalition. Some states, with the exception of a couple, some states have a domestic violence and sexual violence coalition that is one organization. Other states have a domestic violence coalition and a sexual violence coalition that are separate organizations. But we are a resource for all of you, for anybody who is working on any kind of area related to domestic violence. So I encourage you to reach out to your statewide coalition if you ever have any additional needs about training and support and those kind of things. My background, I'm a social worker by training. I've been here at ODVN for almost 18 years and have been doing this really interesting work around the intersection of domestic violence and brain injury. And we're going to talk a little bit about what we've learned kind of thinking about this whole topic of how domestic violence and brain injury and recovery and working with women with substance use disorders, how all of those pieces fit together. And now I will pass the baton over to Cheryl for Cheryl to introduce herself real quickly, and then we'll get going.
Good morning, everybody. Thank you, Rachel. And it's wonderful to be here. Wonderful to see so many people from lots of different places. As Rachel mentioned, my name is Cheryl Stahl. I am the Substance Use Mental Health Program Director at the Ohio Domestic Violence Network. Previous to my time at ODVN, I am a licensed professional clinical counselor in the state of Ohio. And for 18 years, my clinical work was with people who are using drugs or are dependent on drugs. So I come from the clinical counselor space. When I started at ODVN, started working with Rachel, started really thinking, as I learned about partner-inflicted brain injury, which Rachel will talk about, I really started thinking about brain injury resulting from overdose, which is something that, at least in my field in Ohio, was not something we were talking about ever. So I will, as Rachel said, we're going to try to show those intersections and the importance of really holistically looking at how survivors present in different spaces. So thank you all for having me.
And Cheryl and I, if this was a perfect day, would have about 3 days to talk about this. And I don't know if we've ever tried to do this in 30 minutes, Cheryl, but we're going to try to give you just
We
an
got this, Rachel. We're going to do it.
Yeah, we're in trouble. And we're not gonna get, if anybody is older, remember those, what were those car commercials where the people would talk really fast? We promise we won't talk really fast to get through everything. But what we're hoping to do today is really just kind of put this issue on your radar. Right, Cheryl and I will make sure to share our contact information and our email if you have any additional questions or need any follow-up. We love talking about this and thinking about this whole topic in this issue. So I'm just going to get us started, like I said, with sharing just a few slides about this, kind of thinking about this intersection of of what we think about treatment for women with substance use disorder that experience IPV and brain injury. That was a topic we were kind of tasked with. And when ISA first reached out, we have, done some work together around domestic violence. In the past, I really wanted to reach out to Cheryl because as I said, I've been in a kind of in a systems role at the statewide coalition for a very, very long time and have not worked with, I don't have the experience working with women in recovery, and, who have substance use disorders and what this all looks like. So this is kind of what we're going to be doing today is just kind of going over this. And I have a few questions that I'm going to pose to Cheryl. We'll kind of be back and forth. We do a lot of training together. Just to kind of, and I'm going to start by kind of laying the framework, and then we'll talk about kind of a few issues that have come up and very, very much encourage you. One of the things that, Cheryl and I always talk about is like once this becomes a part of your thought process and your knowledge, for both of us, we had spent a long time working in our respective fields without ever considering some of these intersections. It's something that's very, very hard to unsee. I always say if anybody has ever shopped for a new car, and if you're ever looking around for a new car and then you're driving around and you see the car everywhere, we have people all the time who talk with us about experiences that they've had with clients or survivors that same day, that last week, when we think about the histories of violence that happens with people who are, have substance use disorders, the history of brain injury and what that is. So we're hoping that this will just, again, make you want to learn more about this and think more about this and really start to have those conversations and do that learning in whatever space that you're in. So we're going to start real quick by talking about these intersections of violence, overdose, and trauma, behavioral health concerns, which I think we've talked about for a long time. I think that many of us who work in respective fields, whether it's in violence or crime victim services or human trafficking, in substance use or mental health or behavioral health fields, and trauma, we've been talking about that topic for a very, very long time when thinking about trauma-informed approaches and trauma-informed care. But as for me, having been somebody who's been in the domestic violence field for over 20 years, it wasn't until 6 or 7 years ago that brain injury was even something that ever crossed my mind. And I think Cheryl and I have both become very, very convinced that anybody who is working in a system that is primarily addressing issues of behavioral health, primarily addressing issues of violence, brain injury is one of those things that could be having a significant impact on the people that we're working with. So just to kind of lay the framework, and again, this is of course way quicker than we ever like to do this. So it's going to be, again, a very kind of broad strokes, is really laying the framework of domestic violence and understanding domestic violence is this pattern of behavior that is used to really gain and maintain power and control over somebody. It can include a lot of different tactics, and we actually have a 3-day domestic violence advocacy fundamentals training. We will make sure you have information about our organization. We have lots of training opportunities available. We have an e-learning library that has lots of online courses that are available for free. And we could talk about this, just this slide for days. But we really want to understand that one of the ways that the dynamics of domestic violence is one of those things that can really play a significant role in people using substances, in people accessing services, in the initiation of substance use, and how mental health problems can occur and how they happen. But we know that coercive control's goal is really to strip away a person's freedom and sense of self. So some of those tactics, I think the other thing that's really important to understand about domestic violence and abuse is that it is not something that is always very obvious. It is not something that happens. It's something that often happens slowly, that happens over time. I wish one of the things my first job was in a domestic violence shelter that I had really understood about domestic violence was that, people who use violence aren't these terrible, horrible, awful people all of the time. But we can see all of these different ways in which it can happen, which including minimizing, denying, and blaming. And it can include some of those migraines, those mind games, the surveillance where someone is being watched or followed, or we think about technology and how that works. But domestic violence is one of those pieces that is really, really just an important factor. And thinking about how people's relationships impact their substance use, impact their mental health is just a really significant piece that we want to consider. And then when we talk about different types of domestic violence, we know economic abuse can happen. We know economic abuse can be one of the big, big barriers for domestic violence survivors. Sexual abuse, psychological abuse, physical abuse, emotional abuse. I would add technology abuse. We're learning more and more about how technology and all of the different ways in which technology can be used to track people, to follow people, to control people, where people are able to know where people are, what people are doing. And that is something that is kind of constantly evolving and changing. So that's a really, really important piece for people to think about. And then I want to talk real quickly about substance use and mental health coercion. And I wanted to kind of pass this over to Cheryl. We have a couple of slides about this, but see if Cheryl, you could share a little bit about just kind of like what is substance use and mental health coercion, and in your work with women who have experienced substance use disorders, how have you seen that show up in your work?
Sure. Substance use and mental health coercion, often when you have survivors who are using drugs or have mental health experiences, abusers can leverage those issues, concerns, experiences against systems and against the survivors. As you see on the slide here, abusers, if the survivor doesn't come to the relationship having used drugs, sometimes abusers will introduce drugs or alcohol to their partners. That, of course, creates a greater sense of vulnerability. And if any of you have familiarity or have worked with people who use drugs, or who are dependent on drugs, you know that, of course, drug use can make them more vulnerable for a lot of things. And abusers use that against their partners. They can force their partners to use even if they don't want to, or in ways they don't want to. So you may have a person who was, say, snorting heroin, not injecting heroin, but the abuser may force intravenous drug use, which, of course, at least working with the clients that I worked with over 18 years, once they used drugs intravenously, they didn't want to use them any other way. So if a drug could be injected, it would be injected. And of course, that increases dependence potential when you're using intravenously. Oftentimes, and I saw this with my own clients, the abuser would tell other drug suppliers in the area not to sell to their partner, and that they would procure the drugs and give them to their partners. And if they found out that their partner was getting drugs from someone else, then the partner would pay for it. So either physically or in some other terrible way. So they would prevent other they would make the survivor or their partner dependent on them and them alone to get the drugs, make their partner dependent on them for money to get the drugs, and withhold money for drugs as punishment, which then can force a person into withdrawal. If you're using a drug that has a high withdrawal potential like heroin or fentanyl, the withdrawal is pretty terrible. It's a pretty severe illness, and people who use drugs with withdrawal potential will avoid that sickness with everything they have. But if an abuser is withholding money or withholding drugs and forcing them into withdrawal, of course their compliance to do what the abusers want them to do certainly increases. I'll do whatever you want as long as you give me the money or give me the drugs. Of course, abusers may prevent partners from seeking treatment or preventing them from attending appointments, support group meetings, things like that. I had many clients whose abusive partners would not allow them to attend groups because our groups where I worked were mixed, male and female. And so they didn't want in the case of male perpetrator, female survivor. They didn't want their partner in a group with other men, and they didn't want them at support group meetings, usually for the same reason. But overall, mostly why they don't want them to attend is the healthier they get, the more they see what's happening to them. And if they're going to treatment, they're in recovery, they start to gain more power, they start to gain more strength, or they become more empowered, and that takes power away from the abuser. So the abusers often will interfere with that healing process. I had clients whose partners used their Suboxone and their other medication assisted treatment drugs to curb their own withdrawal, or if they couldn't find drugs, the abuser would use their medication assisted treatment or opioid medication. And I don't know if any of y'all have ever worked with anybody whose Suboxone went faster than it was supposed to, but typically if that happens, the assumption is that person is abusing their MAT, their medication assisted treatment, and they will not get more. So then the person who's actually is prescribed to can't use it and can't get it. And of course, abusers often report their partner's substance use to various other systems that the survivor is involved in, like probation, children's services, etc. So in this case, an abuser may force drug use or threat of bodily harm or even death, force drug use, and then pick up the phone and call probation and say, hey, you might want a drug screener the next time she's in. I know she's using, and hey, listen, I'm just trying to help her. I really want her to get off these things, but she's using, and you might want a drug screener, and it gets her in trouble. I have many clients who went back to jail because they had positive drug screens, and their partners were responsible for them using, and then called and reported them.
And then just could you talk just real briefly, Cheryl, for just a couple of minutes about just mental health coercion and kind of what that has looked like for you?
Sure. So mental health coercion, similar to substance use coercion or substance coercion. In this case, of course, leveraging mental health experiences against the survivor in many ways. For example, just the language that can be used, referring to their partner as crazy or insane, you don't know what you're talking about, you're out of your mind, and then making them feel like they're losing their mind. I had a client whose abusive partner would move things around just a little bit, change like where the silverware drawer was. Maybe it was to the right of the sink. Now he took everything and put it to the left of the sink. And when she would say, like, hey, I can't find this or that, he would be like, you're crazy. You're losing your mind. It's right where it always has been, right over here. So that's kind of leads to that gaslighting a little bit, like just making them question their reality, which also, of course, keeps them vulnerable and dependent on the abuser. I'm the only one that can keep you safe. I'm the only one that can protect you against all of these things that you're fearing are happening, and like in the case of hallucinations and delusions, if a person thinks someone's watching them or following them, the abuser may say, yep, I saw that car driving by, you better stay inside all day today, don't talk to anybody, don't go anywhere, because I saw that car today, and you could be in a lot of trouble. So now the abuser's in this position of I'm your protector, and I'm now feeding into these hallucinations and delusions to be both your protector and the person that of course is harming you. Preventing access to medication or now not allowing medication, and then of course leveraging that against systems, saying, hey, I'm trying to help her take these meds, she's refusing to take them, and that can have a pretty negative impact on survivors when they're trying to get custody of children back, they're trying to get off probation, things like that, where they're not complying with the recommended treatment. That then is a strike against them. And of course, preventing access, just like with substance use, not allowing them to go to treatment, not allowing them to go to support groups, making them miss appointments, things like that. So similar to, but different dynamics involved with mental health coercion, but both equally damaging to survivors, for sure.
Perfect. Thank you, Cheryl. And now when we're going to talk, and Cheryl, just to let you know, it's already 11:20, so we got 10 minutes left. We've never done this in a half hour before. But one of the things that, again, we want to try to do when we look at, you'll see right here, this kind of charter graph when it talks about domestic violence, substance use, mental health. These are what the DVSU, mental health, and brain injury. Sorry, we weren't able to figure out how to spell all of those out in this chart when we put it together. Just really seeing how those four things connected. When we see about how domestic violence causes trauma, and coercive control can impact substance use, and DV can contribute to behavioral health problems and cause brain injuries. We see substance use, trauma can cause or increase risk of substance use. Substance use increase the risk and severity of violence, just like all of these interactions. And if we could have made, this also a Venn diagram with 4 overlapping circles, that could have worked too. We know, trauma causes or exacerbates mental health issues. Substance use can exacerbate mental health issues. We talked about some of that substance use and mental health coercion. And then this kind of wild card that came in there for Cheryl and myself is this brain injury piece about how people can get brain injury from physical abuse or DB. People can get brain injury from substance use, from overdoses. Brain injury can lead to substance use and make recovery efforts more difficult. Brain injury can cause or contribute or exacerbate mental illness and can make treatment more difficult. And again, brain injury kind of being that key missing piece that I think, Cheryl and I for many years have recognized the domestic violence, trauma, substance use, mental health connection, but not the critical role that brain injury is playing in this. So Cheryl, I wanted to see, this says we have 2 more questions in these last few minutes that we have together, but I just wanted to see if you could just talk real very briefly about how has domestic violence and brain injury created challenges to accessing services. So we're going to have that question, and then maybe we can also, we'll do that. And then we were going to ask about what are some strategies that have really helped when you're thinking about working with survivors.
Well, I would say there's many different ways in which these things create challenges. So I'm going to try to kind of narrow it down to just a few. With domestic violence, much of which we just talked about on the mental health and substance use coercion, that can create a lot of challenges for accessing services. You have an abuser who's not allowing access to transportation, not allowing them to leave the house, not allowing them to engage in any treatment services that can improve their partner's situation. But I think when you throw brain injury into the mix, and when I look at recovery from the standpoint of working with people who were substance dependent, when they stopped using drugs and got into recovery, often what we would see, or at least getting into treatment, what often we would see were these behaviors that would happen in groups and in individual sessions that we would look at, and I say we meaning therapists, other counselors. We would say, hey, I think they're just resistant to treatment. I don't think they're ready for recovery. They're not, they're not engaging in treatment the way we would hope that they would. Some of those behaviors being not showing up for appointments, sitting in group with sunglasses on and a hood over their head, falling asleep in group, not paying attention, engaged in the group process. And we would say, hey, they're not doing what they're expected to do. Not one time in all of those years did we ever say to each other as colleagues, like, well, geez, they've overdosed 12 or 13 times. Maybe there's a cognitive impairment happening. Maybe the lights are affecting their eyes and giving them a headache, and that's why they have sunglasses on in group, and that's why they have their hood over their head. Maybe 3 hours for a group session with only 2 breaks is a lot for a person with cognitive impairments. We never talked about that. We never adjusted our treatment regimen to be thoughtful of people who may have had brain injuries resulting from overdose, because it's just not something we that was ever talked. It wasn't talked about when I went to school. It wasn't talked about in, again, colleague to colleague. So when you put brain injury into the mix of this, you start to see in treatment, in assessments, not asking the questions after someone tells you that they have an overdose, really just asking them, have you felt any differently from your last overdose? Do you notice any changes in your thinking, your emotions, your physical self? Have you seen a doctor about that? Are you getting headaches? Are you, any of those questions that could be really good follow-up questions to someone sharing that they've overdosed. We weren't asking them. And had we asked them, I guarantee you, we would have found that a good majority of the people that I worked with over 18 years, and there were hundreds of them, would have probably been diagnosed with, or at least we would have been led to the conclusion that perhaps there was some cognitive impairment involved, for sure. And that would have hopefully affected how we did treatment for them. You're muted.
I know I'm on mute. Got all excited. So maybe as we wrap up, because again, I know that we only have a handful of strategies left, and I did want to share this whole thing. What about some strategies to integrate knowledge on unrecognized cause of brain injury into your work? And I am going to share a resource. So I'm going to just talk about what Cheryl, give me just 1 second, then I'll come back to that question. I think when we think about some of those next steps, we really want to talk about educating ourselves, learning a little bit more about brain injury. I'm going to put a link to a webpage that we have about information related to brain injury and domestic violence, thinking about what are some of those accommodations and strategies that we can use to provide services in a way, Cheryl kind of talking about it. What does that mean around brain injury? And then some of that additional collaboration. And I'm going to put a link to our website on our brain injury information, and wanted to share one of these. I wondered if you would just talk a little bit, Cheryl, about some of the things, just some real quick tips about what are some of the ways. You talked about asking some of those questions, but how do we really work to make our to kind of integrate a couple of tips on integrating some knowledge of brain injury into the work that we're currently doing?
Well, I think first and foremost is just asking the questions. And if you know that there's a person that you're working with, whether it's in a clinical space or whether it's not, it doesn't really matter that you're a clinician or not a clinician. But from my perspective, when I was working with people and doing assessments, when we found out that people were in violent relationships, follow-up questions about, have you ever been hit or hurt in the head? Has your partner ever done anything to restrict your breathing? Or in the case of strangulation, or sat on your chest or made it difficult for you to breathe? Like, just asking those questions. Have you ever been unconscious? To really lead the person asking the assessment questions to say, hey, here's some education about brain injury resulting from intimate partner violence. Similarly, with substance use, finding out that a person has overdosed when you ask the question, or if a person confides that in you, just really being thoughtful about asking, like I mentioned before, have you felt different? I had clients that overdosed many times, and just really asking, have you felt different? Has anything changed? Are you experiencing headaches? Are you experiencing pain in the head, neck, or face? And I will say, in addition to the overdoses, I was the program manager for a 23-bed women's recovery housing facility. So speaking specifically about the women that came in and out of my program, again, many women that I worked with over 6 years, most of them, the vast majority of them, had previous history of domestic violence or some kind of trauma, sexual trauma, intimate partner violence. So, in addition to using drugs or overdosing from drugs, they were being physically abused by their partners. So, you have kind of that dual situation of potential for brain injury there. So what you're seeing on the screen right now, I had the pleasure of working with Dr. Corrigan at the Ohio State University West Wexner Medical Center, who's been doing brain injury work and research specifically around substance use for many years. And in talking with him, we decided, hey, let's come up with something for group work. These on the right-hand side of your screen, which is the back of that sheet, these can be applied to really anything. I think the good news is with making accommodations for people with cognitive impairment doesn't necessarily have to cost you money. It doesn't necessarily have to mean you have to switch everything up that you do in your program. You can make what is seemingly small changes to things that can make a huge difference for somebody. So you see in here shorter group length or potentially shorter sessions when you're meeting with them, frequent check-ins every 10 or 15 minutes or so, just making sure that they're following along, that they're understanding the information that you're giving them, orienting them to the processes of and rules for your program, and making sure you're checking up with them. If they're having any behavioral issues or problems, really just making sure that you're talking with them and asking what's going on. And if there's any way that you can be helpful, kind of with whatever these behavioral concerns are, um, identifying those problem behaviors and providing feedback, uh, checking in regularly, as I mentioned, just to make sure that they're following along, reducing overhead lighting or like fluorescent lighting, so that minimal changes you can make. And I know we're at time. So just minimal changes that you can make. This is available on our website. I believe there's a link to that on there already. Yes, Rachel's saying yes. So you can use this. There is an accommodation sheet. I think Rachel's going to put all kinds of links to our resources in the chat. So please feel free to access them. Please do not ever hesitate to reach out to me or Rachel for any questions or any further training on these issues that you may want or need. Even if you're an out-of-state person, which many of you are, Rachel and I are always happy to help other coalitions and other programs in other states besides Ohio.
You put on your evaluation, you want more information about brain injury for a longer time. Thank you all for joining us today.
Thank you very much, Rachel and Cheryl. This was incredible information given to us very quickly, but we really appreciate it. No, that's great. And along with all of the resources, we will make sure that those get posted on the website. And have a good day, everyone.